because I'm really lucky that she has agreed to do this for me. We're buds. We're personal friends, full disclosure, from when I was at the University of Florida. And when I was there, I knew her two daughters, and my daughter babysat for her daughter. So that's full disclosure, we're buds. But what's more important for this presentation is that over the years, I've read some of her work, and I've advertised it and pitched it. I wanted her to focus on CBPR. I wanted her to tell us about community-based participatory research. We don't have a course here on it. Someday we'll leverage the capability to take courses remotely. I would love to have modules like that, have those sorts of very special kinds of research methods that we don't have the expertise here that we could get that done. And so this is sort of a little bit of wetting your whistle of understanding what CBPR is, and more importantly, for those of you who have a particular interest in migrant populations and in population health, and I know my good friend Dr. Lamote said she wouldn't miss this, and particularly in diverse communities. Dr. Stacciarini has a stellar reputation, and she's agreed to do this. As I said, full disclosure, we're buds, but she has agreed to do this. I'm going to turn the screen over to her by changing the presenter. We rehearsed this, full disclosure. We never know if it's going to work, but we shall try. We shall try. So you should be able to take over the screen. And I should be able to close this.
And can you see my slides?
We can.
Fantastic. So it's a pleasure to be here with you all. Today's a holiday here in my town. It's homecoming, but it was so perfect because I'm totally connected with you, so I don't have to worry about anything else. I'm going to be talking about CBPR, but also I'm going to use the work I've been doing to very briefly touch on some of the methodological aspects that we have been using within CBPR studies. Can you all hear me well?
We sure can. Yes.
Yeah. Perfect. Perfect. So most of my work has been in rural Latino. We are now extend to other populations, and I'll be briefly mentioning that to you. So a few things about CBPR. All the work that I'm talking to you has been developed for about 12 years. So I've been doing, and I have done several studies with similar community, expanding to other counties, going back to the regional counties. So one very important thing in CBPR is the long-term commitment. So you have to know the community, you have to develop trust, you have to have the community members as partner of your research. So some of them are participants and some are partners. Very important to get to know the culture and have their help in understanding how to be in the community. So flexibility is another principle of the CBPR. So in fact, you don't have the total control of what's going to happen and how it's going to happen. So CBPR, for me, in a very simple way, means working with a particular population, working with, but also working for. So that is essential aspect for those who have interest in CBPR. So the ground principles is, so you have to you have to develop, and you have to engage, and you have to participate. But for us as a researcher, I think one very important is how you're gonna engage and how you're gonna connect. And beyond that is the wellness approach, because particularly because of our culture in America, we tend to use more treatment-based research rather than preventive research. So wellness is one very significant aspect of the CBPR. I will show it to you when I first start pieces where I didn't fully use in the whole capacity. So as a naive researcher, when I first started, we had mistakes, we had to go back, we have to connect again with the community. So I'm gonna share positive aspects, and I'm also gonna share challenges that we encounter in our reality. So throughout these years, I have worked with mothers or women in rural communities. I have worked with adolescents. We have worked with different denominations of based faith organizations like churches. So when you go to rural areas, you can encounter church in almost every corner, particularly here in Florida. I also have worked with mothers, adolescents, and fathers, so families. So two studies that we did encompass the family. And most recently, we are working with adolescents whose sexual orientation is LGBTQ. So just to give you an idea, the size of the circles, it's not a circle, it's oval, is related to the funding that we received. So we had small funding, we have a larger funding. So those here represent a little bit of the size of the funding aspect that we received. As you can see, a big one was study 4 and 5, and I'm gonna be focusing more on those. But I will start talking about study 1 because it really set the way to go into the community. So we start developing a community advisory board, and we were very clear with members of the community, like we want to start a research in mental health, which is my area of expertise. We want to connect with the rural Latino population. Can you help us in this process? And keep in mind that this CAB, or this advisory board, has been active since now, but the community is a fluid process. So you don't have a control for how long they're gonna be in the CAB. Life happens, people change workplaces, and they go and they live, and so there are many circumstances. In this time that we have been working with the community, we have 4 members that have been since the day we start. And right now we have about 10 participants in the advisory board who are members of the community. Who are these people and how we get these people? So they are advocates, they are Latino themselves, they are from the community, they have some influence in the community, basically the connection of developing the CAB is through a snowball. So you talk to people, you ask questions about people who they think would be a good presence in the advisory and who could influence the work we could be doing in the community. And just to give examples, we had director of public health, who is a nurse and very committed with the community, and she's still in the CAB until now. We have one teacher from high school who has been in the CAB since the beginning, and the same person is connected with a church who has been very supportive to the work we do. And another thing is to have like a general goal for the CAB for the beginning, and as evolving to make sure that you tell the CAB members what are the main aspects that they are doing. So when we start the CAB, we want to understand what were the social problems and the health issues of the rural Latino community. So very broad, very broad. Initially, I had in mind to work with women. And they said, well, we also need someone who works with the kids. So I had never worked with the kids before. And that time I had to go and find some colleagues who were experts in kids, doing research with kids. And we were able to have a collaboration at the university side with an educator and also with a child psychologist. So as you learn the needs of the community, you have to also evolve with your research methods and with the intellectual capacity that you do have in your research. Another important thing is to respect the way the members want to voice and how they want their voice to be registered. So initially, I had in mind in tape recording, since I have expertise in qualitative and quantitative, I thought the CAB process would be through more qualitative, to listen to their contributions, to listen to their community knowledge. But they were uncomfortable with the idea of every meeting to be recorded. So we learned about scribed notes during all the meetings that we had with community leaders. And the scribed notes are taking notes, having someone who you can train, and having someone that is going to be taking notes during all the meeting, not only about the verbal contents, but also the agreements, disagreements, tone of voice, faces of uncomfortableness, and all of that. So every meeting will have some notes, and the following meeting we'll bring the notes and validate it with the CABs to understand if that was what they wanted to register from the past meeting, or if we had missed anything. So with the collaboration with the CAB, I embarked to the study, the second study. And basically, our main objective was to identify depression symptoms, stress, self-esteem, and culturally sensitive treatment strategies. So as you can see here, I went a little beyond of the wellness aspect. So I was, in fact, focusing on depression as illness. So that was our first challenges with using some instruments that reflect the principles of CBPR. One interesting thing was in this study, we were using community workers, we were collecting data in participants' house, and one of the things that we wanted and we did was some kind of field work notes that brought a light for us in terms of the psychosocial health determinants, which were more important for the participants. For example, when we were asking questions about depression, suicidal, they were talking about challenges, social challenges. For example, the fact that they were undocumented and need to hide themselves very often, or the fact that they didn't have food every day in their house. So we were able to start capturing based on the field works that the community health workers were telling us about. We also had a big challenge. We are in a health science center, and our IRB is very hospital-based. So our study was not being approved based on the community engagement that we were proposing. So that was a very intense challenge. I was uncomfortable with how people were responding to the engagement that we had proposed. And when we talked about that in the CAB meetings, the director of the public health, she said, no, you know, this is not acceptable. This is what public nursing is, public health nursing is. We go to their house, we meet in their churches. That's what we do as a public health nursing. So she actually went to the next IRB meeting with me, and our study was approved. So having her presence was phenomenal. She really spoke from her experience, from her knowledge. So I brought the community to the university to really demonstrate that what we were planning was something that is not uncommon when working with hidden population. So, and as I mentioned, I also used the log, which was a descriptive qualitative information. So our third study, because from the second, we learned that church was considered a safe place. So they want us to be engaged with the church. They wanted us to meet with them in the church environment. So that was probably a year and a half or two of hard work, really connecting with church. That time, I remember my husband asking, which church you like most? What is your religion? So things that for people outside the CBPR, they could not understand the value of being part of the services, the value of learning how to engage with different denominations. So just a little disclose, I'm not a big fan of church, and but that was part of my work. I had to learn so much. And one big challenge that time was every church wanted me to be part of their religion. So that was a struggle, because I was like, oh my gosh, I'm not a member of this church. How I'm gonna, translate this? So that time we engaged with the religious studies at UF, and we learned a lot about how to connect with church. So basically I changed in the way I was talking to them. So basically I would go and say, thank you very much for opening your house to us. I understand that we have a common denominator, which is social justice aspect. So we are not talking about spiritual engagement. We are talking about social justice perspective. So I went to several mass. I went to several services. I learned to meditate in the churches because I had to be quiet and silent there and be present. So it was a very intense and long process, but we got their trust. So we also did some qualitative work with several churches to kind of understand what they thought was the social health determinants, and what they thought was like the problems that this community had. So we were able to capture three main themes: political context, social class context, or social inequities, to tell you more, and also some individual context, behavioral factors. So basically the church leaders, they were telling us, we work particularly with 5 churches that had a larger number of Latinos, different denominations, and they were saying, being undocumented is a big problem, big social health determinant that influence what they do and how they can do. Geographic mobility was another big aspect, how they had to travel. So sometimes within this the same zip code, they had several churches, and how they traveled and how hard it was for them to travel, particularly not having the license to drive. Another thing was the linguistic and cultural knowledge, and also that they were not able to take advantage of building capacity on that community. So all or majority of them had very hard work. They were farm workers, and those who decide to settle in the place, they would just jump from one farm to another farm and doing always farm work. And another thing we learned that was related to individual contacts was some drug abuse issue in the community, domestic violence, and those kind of things. So, and all the church said to us that involvement, engagement, and trying to create some kind of unity would be the best way to help this community in terms of social justice work. So one thing that I want to emphasize was the importance of keeping connected all the time. We don't go to the community just to collect data. As CBPR says, the researchers needs to be out there. So we were connected in community, churches event, school events. We had one interesting situation that one particular church said, oh, we're gonna have a fair coming up soon, and we would love your presence. And I said, oh, of course I can be there. It's really my pleasure to be there. And they said, well, but at this time, we don't want you to talk about social or mental or health issues. And I said, oh, how can I help? And they said, we need you to offer free flu shots for the community. And I don't have flu shots available to, I didn't put that in my budget. And I was like, well, not sure. Let me see how I can help you. Give me some time, and I'll try to see if I can help you with something. So I again connect with my best community partner. And I said, you know, I just need some. We are engaging with the community. They are requesting for this. It's a flu season, and they really need that, and they can afford to pay. Well, let me think what I can do. And she came back and said, okay, I got 70 doses of the flu shot for you. They are free. I'm also donating the time of my nurse to give the injections, but I'm gonna need you there because my nurse doesn't speak Spanish. I said, that's not a problem, we can do. So when I got there and I started seeing the line, people were lining up, and I just started counting. When I finished 100, I saw that the line was keep going. So I called her and I said, teach me how to do it. How do we select who is gonna receive this? Are the ones first in line, the ones that are gonna be receiving, or do we have any selection? And I invited her to come up to the church. I said, you know, just come and see, because I never seen this. And she said, okay, and I'm coming. And she came with double of the doses that she initially had dedicated to her. So that day we were able to give for free 150 doses of flu shots. So that also helped the community in a way that they see that you are really invested in their health, and not only trying to do some research and take the data to present some articles. So as I mentioned to you, is working with and for. Are you with me?
Yes.
Yes. Okay. Feel free to interrupt me. I'm going to try to go a little faster because we do have until 1 or 1:30.
You can run as long after you want, but people start to leave somewhere around 1 or 1:15.
Okay, perfect. So study 4 and 5, we were focusing and trying to understand the social environment and social isolation. So we wanted to understand their geographic area, their rurality, and the social networking that this population had. So here were some instruments that we used. And the social network analysis, if you are not familiar with, is like for each participant you ask, can you list 30 people that you connect or you feel that you could connect in case you have some issues? And then we start asking them, do you trust this person? Do you feel like you could have support from this person? So it's that person becomes the authors of the networking, and those participants are the egos of the network. So one thing I would like to share with you, which was a terrific learning experience, because this time we included a geographer as a collaborator, and basically we didn't know how to measure rurality, and we were thinking about zip code. And we learned with him, although everyone knows what rural is, how hard it is to measure rural. So in our case, we developed a new modality of measuring rurality, and we include macro and micro aspects. So one very important aspect was the traveling of that community. So we asked them to tell us, and was a journal type, where they were constantly going in the last week. So that was one way that we were able to capture. Here's just a little bit of the travel, the map that we had. And we were in this area, but the population will travel around. Although the geographic aspect was an issue, the traveling was hard, but they were going to other places. And this map shows it to you the social, we were here in these 4 counties. They are more north central Florida, and the furthest that they would get away from that, from their houses, the less social isolation they had. For example, I am located here in this area, which is Gainesville. So a lot of the participants that will come very often to this area, which is a little less rural, they had less mental health issue and less social isolation. So those that would travel a little far from their own zip codes, they would have less social isolation. Here, the blue means high social isolation. The one yellow and green, it's less social isolation. So we also use their traveling aspect to really understand where this population would, the likelihood of this population to have face-to-face meeting, although not all of them knew each other. So that is particularly important, because then we identify that we could use a church to develop some kind of network, some kind of intervention to start that where people would go to. So that was, for example, we had people talking to us. The primary place that they would go was church. And in a population of, I think this was the 4th study, but in a population of 60, they mentioned 141 different churches that they would go to. So they go to churches not only for spiritual affiliation, but also to connect with others and to get some kind of social service that the churches sometimes offer. So this one also using the rurality measures. So here on the left is the social, and here's the mental well-being of the population. So the larger the knot is more social isolation, but they were connected with others who didn't have high social isolation. And exactly the same happened here. We perceive that some members were connected. So F means father, M means mother. So for example, this couple here is indirectly connected with someone here who has a much better well-being. So that is important for public health and mental health interventions. In the whole community, we were able to identify, in the whole community of 90 families on this study, we were able to identify the type of a structure of the networks they have. And the most common was a very close community with connection with family members. Here we had connection with few outside and some that would help to connect them. And this one here is primarily with the kids. So they network very closely with the family and somehow close with the schools. So I'm gonna jump this because I already mentioned this. The networks they trust the networks they have, but they consider that the network is not supportive, which makes sense because they don't have the social, the intellectual, and financial capital to support them, to support the community. And social isolation is not only being away from other people, but it's a much broad aspect in terms of cultural, linguistic, and geographic. So for us, we found that that is the main overarching theme as a social risk factor for mental well-being in the whole community, including mothers, fathers, and adolescents. Women seem to be a little higher, seems to have higher scores on social isolation and lower scores on mental well-being. And also when we look at couples, women had significant higher social isolation and lower mental well-being. So social isolation for us was found to be significantly related, particularly with mothers and kids. And then church, again, is considered a safe place. So here is just a little demonstration of a study that one of my undergrads did. She ran a qualitative photo voice study, and basically she asked a few women to tell about their rural environment. And this one was a phenomenal work because the CAB had asked us to somehow have ways of presenting to the larger community about the lives of the immigrants. And using pictures, we were able to put in other churches without identifying the participants. So basically, she did with 20 women, and none of them put any human being in the pictures. So their lives are around roads, empty roads, very dirty roads, parks that are empty. When they go to their kids, there was no one for them to connect it. Rural is in an environment to give food to their kids, to have some tool to connect with their family back home, and also animals in their lives. So this was a very powerful, although small in size, but it was very powerful because then the students were able to portray and to show up these pictures in some of the churches. So with all the information we had, we developed a church base, which is not religious, a social health determinant intervention. So this intervention is focused on engagement, on participation, on trusting, on reskilling the cultural knowledge, and also trying to move beyond professionalization. For example, a lot of the participants said that many times when they would disclosure in schools, they would say, you know, let's see if they would disclosure that they were sad or if they were homesick. They would say, well, let me talk to the counselor and see if we can send you to a psychiatrist in the community, which we had one for, I think, 5 or 6 different zip codes, and the zip codes encompass a large area because it's very rural. So what we saw, it's the social aspects was becoming a way to be to have a diagnosis, a psychiatric diagnosis. So we try to move beyond that, and that the way was we had a community worker that was trained to work in a church, talking about the social issues and how they could learn from each other. So in our mind, the medical care alone cannot improve health disparities. And so we think that we have to address where and how the relations of people. It's expanding. It's we are working with farmers and farm workers. We have a lot of farm workers that were able to be very successful and became small farmers. And we are now expanding our population from Latinos to also work with Haitians that are coming to this area. So, and we are also looking at economics outcomes. So most all the studies we have were mixed method study with involvement and with the perspective of focusing on the community and trying to understand this social injustice and the social relation to mental well-being. So I'm open. Now time for us to talk.
Okay. Okay. Why don't you pause for a moment, since you've been talking straight now for almost 45 minutes, and see if I know there are a couple of people who probably have their own experiences in rural communities, and perhaps you might introduce yourself so that Dr. Stacciarini doesn't feel like she's talking to people who have no relationship at all to what she's saying.
Dr. Stacciarini, I'm Kathleen Lamoot. I'm here struggling because I've had the experience of working with community-based participatory action research. However, in an extremely poor community in Haiti that I had worked with for over 6 years. And I had my network, I had my advisory board, I had church, I had community leaders, and I had so much difficulty. Community-based participatory action really is founded on equality, and that really doesn't exist when you have such a different community that you're working with. So I struggled with that, and I struggled with, although after more than 6 years working with the same community who knew me, who trusted me, there were such cultural differences that I failed to really understand some of the important things about the community itself. So it was very difficult for me, and it's actually difficult to talk about it because I spent so long working with this community. And what I did find was that there's such perceived inequality between the researcher and the community that you can never fix that. any reaction to that? I worked with the community to identify nutritional problems. I had done a quasi-experimental research project for malnutrition, to treat malnutrition for 6 months old to 6 years old. And I spent quite a bit of time doing that using ready-to-use therapeutic food. But I couldn't keep doing that. It was very expensive. So I worked with this same community because we couldn't treat the pregnant women and we couldn't treat the 12-year-olds because the study itself was up to 6 years old. But I, as a nurse practitioner, I had been treating this community for years, the pediatric population. But of course, the mothers come with the pediatric cases. So we had meetings, we had so many planning sessions, but underneath there was a cultural, I don't know, I would say they didn't speak out as much because that's not in their culture. And the representation of someone from the United States equals someone who has money. And that interfered with the actual project. And I don't know if I'm...
No, I think this is good because this is, I wanted to just add too, so that she also knows that I didn't understand rural till I knew those dirt roads in Florida, and many of us don't have a real understanding of that. I knew you did because you know rural and you know cultural differences. So I wanted to be able to talk about those sorts of things, and I love that she talked about IRB too, because those become real. So
the whole concept of equality, I think, is almost impossible, because as a more educated person, I mean, the population I was dealing with were extreme poverty, and they couldn't read or write. And now someone who's coming in and treating children, and you can never equalize that.
Did they not trust you?
No, they did trust me.
So
But
what was they had a perception of her as?
I had a friend who lives in Haiti that I connected with through my research. She went, I think, 25 years ago to Haiti to do her dissertation, and she never left. And she married a Haitian, and she lived in a completely different area of Haiti, but we connected and we, worked together on many things. But she finally said to me, Kathy, you don't understand. They will never say no to you. If you discuss things, they will listen and nod. They just won't do it. But they'll never, no matter how much they trust you, they're not going to speak out and say no.
I worked in I had a little team when I was down at Rutgers Camden. It was not rural, but, I worked in Cramer Hill, Camden, New Jersey, which is a Latino population. It's a very stable neighborhood with a lot of poverty, undocumented immigrants, an array of people from a variety of Latino cultures. And like, our colleague here, we worked through the church St. Anthony of Padua, a church which had a very big presence in that community. And, but I think what was an advantage for us is that the college was there in Camden. And so even though we were outsiders, and quite frankly, it was a group of us, women, none of us even spoke Spanish. We brought our nursing students with us as translators, and I would say it wasn't really it wasn't participatory action research in its pure sense. We tried to ground it in kind of that philosophy of some equalization. But, when you were talking about sort of the imbalance, because, the priest would get up and introduce us, and that, created some kind of trust in us that probably wasn't, it shouldn't have been there in that sense. But I think because we were there, just as, UF is there, we weren't like Kirsch says, the friendly stranger who disappears. We weren't coming and going. We were there every week, and, we did a lot of so not the flu shot thing, but we did engage a lot of the public health resources in the city, bring the breast cancer screening van, for free mammographies. We ran a lot of health fairs. We brought our nursing students on Saturdays and Sundays. We would try to capture people because we would show up during and after the mass. And so, I mean, it's interesting to think about why it was, I would say, reasonably successful, but it definitely, I don't think it was equal in any sense. We tried to listen to hear what it was that were priorities for the community, instead of imposing our own impression of what the priorities were, but I don't think it was equal in that sense that you're talking about, Kathy. I think that's
the ideal, and I felt like such a failure with it, but you can't make it equal. I mean, if I was doing participatory action with a group of nurses at a local hospital, yes, you can make that equal. But when that's why I was particularly interested in your work, because of the vulnerable population aspect. And I don't know how to fix that. What has been your experience with it?
I think I can give you a few inputs that perhaps help you to think through. I did have lots of challenges. IRB was a very minor example, but I hold up my study for a few months. So one of the things that tremendous helped my work was the different collaborators that I had at the university level. So when I struggle with the religion, with the churches, I looked for the religious study department. I had sociologists, I had geographer, I had psychologists, I had educator, and I think that collaboration within the university really helped me to carry the challenges that we were encountered. And also in the community, I had several partnerships that really helped, and several that I said, no, let's not go to that way because it's not worth. So, for example, one of the community members of the CAB, she recommended, because they found out that in certain place, some like representatives from each county, they were meeting once a month to talk about the issues of the community. And I thought that could be like an amazing place for me to voice the issues of the community. And we were completely wrong, because basically they were like, are you working with undocumented? Undocumented should not be here. And I immediately said, no, I'm not working with undocumented. I'm working with immigrants. And we never asked for their immigration status. So immediately I felt awkward, and I did never return there because it wasn't a good partnership. For us, when we decide which church would be the best for us to start piloting the intervention, it took us a year to get the permission from the priest to have the intervention in that particular church. And the major reason was he was concerned of people talking about abortion. And I said, you know, I'm a mental health nurse. I'm not bringing the abortion aspect. I'll never talk about abortion. But what we will talk, if they bring it up, is the suffering that they may have in their minds because that had happened. or because they were raped, or because, and then I gave an example to him. I said, one of the families that we worked, we have 3 women that were raped when they crossed the border, and one of them got pregnant, and the mom disclosed to us that that is something that she's going to carry forever, because she came to this country to run away from suffering, and she encountered much more psychological harm. So after I gave that example to him, I said, you know, the mom, when we found her, she wasn't able to step out of her house for 3 months. She could not step out of the house because she had intense psychological hurt. So we never use the term depression. We never use the term of anxiety. We also use the term of suffering because that hits to everyone. So not everyone understands what is depression, and there is such a stigma. So after we talked very open, and I said, by the way, you are welcome to sit in our group intervention and see what we talked. In fact, I didn't want to have him there, but if that was the price to pay to connect with the community, we were welcoming him. So he sat for 3 times, and nothing changed because he was there. The contents of suffering was always brought up. And then after that, he left us alone working with the community. He saw that we were really connected to one big message, which was social justice. So I think the partnership is the biggest issue. Community involvement and helping to handle inequalities is very hard work, very hard work. But I think persistence and trying to connect with other partners that may help you in different circumstances can be a key issue. The last thing is we have had NIH funding, but we now have RWJF funding, and RWJ and us, we talk the same language.
It's in
And
their priority.
it's hard to find someone that talks your language. So RWJ has been an excellent connection. So those are my comments.
So may I ask you, you did a lot of the research knowing the communities, but what specific interventions did you do? And how involved was the community in planning and performing those interventions?
Well, the intervention was developed together with the CAB. So we had a lot of back and forth on how to not work with treatment, which was never the focus, except the first study, but to work on social health determinants. After we did the social network, we understood a lot from the community. It's very hard for them to navigate outside their own culture and their own language and their own physical differences. So the community that we developed was for rural Latino, although a lot of religion was saying we have to create some kind of general unit, but the other members said no, that could be more suffering. So our intervention is on engaging them. It's talking about, we always start the meeting say, what good things we have here to celebrate. And we sing, we throw poems, we do good things. So the idea is not to be there to teach them how to do things, but to reskill their own culture and for them to support each other. And then the major question is, what are the things that are not allowing you to sleep during the night? What are the issues that you are going through? And then we do have family issues, we have kids issue, we have people who are sick and don't know what to do with that, people who don't have food in their house and don't know what to do with that. So after they bring up the main issues, because the meeting is about an hour and a half, we say we cannot work with all the different aspects here. Let's work with the one that you all can vote and think that is the one that we need to work on today. And then they select, the group vote and they select. And then basically we start saying, okay, tell us more about this. And then after we hear the situation, then comes my own or the community worker to bring that social issue or psychosocial into universal level. For example, the lady that had the abortion and that was feeling really bad about that, we say, okay, who here, because many people may have had abortion, but not all of them in the community. So we ask here, who are those who have had a big loss in your life, and how do you handle? So when I transform the abortion to a universal component, that is when the community comes with support. And that is phenomenal because although I haven't had abortion, I have had my loss. Everyone have had some kind of loss. Perhaps when we compare one dimension is very different than the other, but still very important for all. And then people would say, well, I pray. Well, I always would talk to someone. Well, I was so sad that I decided to look for a therapist. And then towards the end, we recapture all the popular knowledge that was brought in to that meeting. And after the meeting, I say, I'm available if anyone needs some information about the issues in the community, about the resources in the community. The resources are very low, but I had partnered with few people. We do have a clinic in the community. I had partnered with them. We did have 3 public health departments that were supportive to our work. So I knew some resources where I could make some referral.
I'm sorry. I have a question about that, having been in the region and having the university hospital being where it is and having seen the dirt roads. A profound experience I had was that we learned that on Wednesday a bus would go by and pick up people at the end of the dirt road to go to people with serious medical problems or particular medical problems. You could bring resources like that as a possibility. So my question is, and it sounds to me even for Kathy's lack of being able to say, here's somebody to go to, or here's a place to have, did you leverage your source of resources in any way?
Yes, but not totally. For example, one of the things that they needed me to solve was immigration issues.
Mhm.
So I could not do it. I could not do it. So what we did, we went to the law school and asked for a donation of time of one lawyer that handled immigration issues to go one day or two in the community and offer some kind. So I was always looking for additional resources for the community. But I was clear from day one, like I do not have a magic ball that I can ask for to do something and do it, because the issues are huge and sometimes you cannot handle. But we were able to help them to think through. So how can you now start connecting? One big thing among kids and parents was the parents were not going to their school. So they were feeling disconnected. So one of the meetings that we had with the community was like how the schools can support. And the school said, well, we can have someone who speaks Spanish and receive the parents once a month. And so we were there moving the community and saying, you do have minimal resources, but you do. So
that's really good to know, because I think one of the major points you're making, and we think of it so lightly, is that this work is hard, because this is, aside from the intellectual and academic aspects of it, the work itself is personally hard.
correct.
And that your ability to be able to sort through and keeping that head of, I hate to say it, being able to collect data and knowing that that's the funder's reason that you're there, but being connected to a community with problems that you can't solve, that is
Yes.
really hard.
Yeah,
So,
yeah. And I had barriers in the academic setting where I was invited many times to not work with this population because you're never going to be funded, because it's unsafe to work with these people. I had people who would say from the community calling my office and say, you gotta stop working with these people. We don't want you. So I had personal challenges, but I never gave up. And I was always motivated to work with and for the community. And I had some mentors that were fundamental, particularly in the beginning, say, keep working, keep working. When you bring money, they will be happy about it. Don't worry about the university, keep working. So, and I think those were good advice.
I think that's incredibly inspiring. I don't know if you looked at all into Molloy College, but one of the central tenets of our work is social justice. And so I think that you have a kindred audience, kindred spirit audience of who all do, and there are other folks here. Before we close, I want to make sure we give other kinds of questions some attention, because but I wanted you to have that as feedback of that we all can understand. I wanted to be able to make the case for this work is very rich. We think of it academically, and then it's very hard. And as I said, I respect what Dr. Stacciarini's done. We have some other communities I know that we might have questions about tapping into. So just to start it off, we have local communities here that are very poor. And so even though we're not rural, they are very poor. Had my own failure in a community not more than 5 miles away of having been part of the community, having spent months and months and months, and culminating into a health fair that we brought, but have not taking it to, but having worked with the community of what do you need, having done that again academically, this is what I wanted to do, but I failed, and I succeeded in having done something, but I failed. So I would like to open up to anyone else who has either thought about trying to tap into it or first approaches or anything else.
I have a question, just curious in terms of when you do the measurement of rural, consider how rural it is, did you also, and I'm wondering about this population as well, how much involved they are in social media? What's the influence of social media in terms of, two individuals, one is very involved in social media, the other is not involved. They both live in very rural area, but the one involved may be more connected with more resources. I'm just curious about in your population, what's the impact of social media among these group of people?
When we start our work 12 years ago, one of the things that the community members said, do not think about connecting through social media. Do not think about electronic intervention. These people need face-to-face. These people need to know you. These people need to know your commitment. So we listened to them. So we didn't, and we noticed that some members would share one phone among 5, 6 different families. So that was quite some time ago. Things are now a little different, and although for the adults, it's still something that they do not entertain, but now with the kids on the LGBTQ group, they are asking for us to, have some kind of connection through social media. We haven't sorted that out yet. We are still in conversation with the advisory board, and we are trying to see how we're gonna connect. And this is even a larger issue because working with the kids, we are trying to work with the IRB to get approval to talk to these kids without their parents' consent, because a lot of the kids are out to some members of the school or the public health, but they are not out to their parents. So if we're gonna have only those that the parents will consent, we'll have a very biased population. So this is something that we are entertaining, but we don't have yet a final decision.
Interesting. Marcia?
Yeah, I have a question. Sometimes in these closed communities, you have gatekeepers. Did you find that when you were, maybe your initial work, what did you do to win these gatekeepers on your side?
Yes, we did, and they were fundamental. So one of the things was to first create the trust with them. So one of the things, for example, we had some few members of the community that will come to the advisory board, and few people wanted to have the meeting in English, but they could not understand English. So anytime we had community key members from the actual community, the meetings were in Spanish, and we didn't have translators. So what I said to them is, say, here and there we're gonna stop and just translate a little bit what is going on here. With that, we developed some trust. Being part of their community was also a big aspect for them. And also serving as kind of liaison for them to identify resources. So one of the biggest issue in our community is dental care. And there was nothing related to mental health. But, well, it can, because depending on the amount of pain you have, you can develop some. But, you know, it's far from the main issue that we were handling. But we were able to advocate, and one of the public health open a dental clinic. So we had, we were demonstrating that we were committed to bring some resources to the community, and also to leverage those resources that were available and they didn't know about it.
Olga?
Yes, in a couple of questions. Number one is when it came to consent, I'm assuming they were offered in Spanish to your population. And second, if you were consenting, everybody who participated individually, or was it a group type of consent? And then the second question, when you talk about how rural, when you determine the rurality based on the distance traveled, I'm just thinking, those who traveled distance, were they also more financially stable to be able to afford, vehicles and gasoline, et cetera, to be able to travel? And that perhaps also they're in a better financial state to begin with. That kind of adds to their, to having being less isolated. So these are the two questions I have.
Okay, very good questions. Thank you for asking that. So the informed consent and the consent form when we were handling kids were all in Spanish. We had a few studies that we were able to do without having the formal, we had some waiver. We were always pushing to have some kind of, and another thing was we never disclosed their full name, even in the informed consent or the consent form. When they were signing, they were just putting initials. So we were able to have that with IRB. Another thing is we got the NIH, help me with the name of that, is the confidentiality.
Certificate of confidentiality.
Correct. So we got that for 2 of the larger studies that we had. Another thing, I think I'm the most well-known researcher in the university with my IRB. So we have 2 different IRBs. I'm their friends. I bring cookies once in a while. I review for them. They all know me. From the chairman of the most difficult IRB, because one of the studies that we got, I had some issues that they were not approving the study until I had some piece of the IRB covered. So I emailed the chairman and I said, you are the most important person here. I have to meet with you as soon as possible to bring $500,000 to our university. So, and he attended my request. And he said, sure, I'm available to you anytime. So, and he was able to show me policies. So I am out there. And when they say and look at me like, are you working with undocumented? I say, well, I don't ask. I don't ask. I don't know if they're undocumented or not.
Don't ask.
It's a big liar because I know. But for Republicans, we cannot work with undocumented.
One of the things that my colleagues don't realize too is your IRB at the university is a locked, it's an entire floor in a building and it's locked and it's staffed with not like ours, I think probably hundreds of participants at all different levels because of the number of offices and the number of things in there. That door is locked. If it's still in that same place in that building, it's locked, and it is it'd be like this whole floor of offices. That is the IRB, not like ours, which is an email away. So
yes,
so there you go.
So I think this is a good advice to get to know your IRB, to connect with them as much as you can when you are handling, you know, hard to reach population. Another question that you asked me was about the traveling of our population. One of the things that we identified was they were traveling to places where they were feeling more comfortable. So they were traveling to several churches. They were traveling to stores where we personally visit and saw that they had more Hispanics as employee. That places that they felt a little more comfortable. So we didn't have like longer traveling distances, except for one participant that we noticed that the family would travel very often to a larger distance. They have family in other area, but they were not going beyond half an hour traveling. So we studied a lot, but a lot of this rurality. Was the most interesting learning that I had, understanding the rurality aspects. So if you consult with geographer, you're gonna understand that they use traveling roads, they're gonna use socioeconomics of the areas, and also now we included the traveling aspect. Because imagine, we are not static human beings. We go to places, and the places we go influence who we are, for better or for worse. So we wanted to understand where these people were traveling to, where they were going to, and we did a lot. If you want to go a little more in depth, we have 2 nice publications about that.
Would you send those a couple of examples for me? I would love to be able to share those so that they can see what the culmination of this work ends up being in print and what that looks like.
Sure.
I'm going to give last call for questions, so we have a chance, or any other kinds of questions before I ask you to join me in thanking my friend, Dr. Stacciarini, and a distinguished colleague who is, I didn't even give the credentials that she has. You've seen those on the handout. But please join me in saying thank you to Florida, New York. A whole class worth of thanks. So I'm going to say goodbye to you and thank you again. I'll be back in touch as soon as I can. And I'll say to my colleagues here, thank you for spending your lunch time on a Friday, first Friday, and in this session. So thank you very much.